how do you convince a clinical trial that a feeling is actually real?
Well, that is the big question.
Right. Today we're looking at a medical field where traditional diagnostics like, an X-ray or a blood test, they're essentially useless.
Yeah, they don't tell you anything here.
Exactly. And a woman's purely subjective reality becomes the hardest data we actually have. So welcome to this deep dive.
Glad to be here.
Our mission today is to explore a really fascinating medical conundrum. How does the scientific community measure something as entirely subjective as vaginal laxity?
It is a profound challenge, honestly. For decades, laxity, which often stems from childbirth or just natural tissue aging, was a vastly underreported issue.
It was just something people didn't talk about.
Right, largely ignored by mainstream diagnostics. But today, it sits right at the center of this huge boom in cutting-edge treatments.
Yeah.
And to prove those treatments actually work, doctors had to figure out how to put hard numbers on an intimate, subjective feeling.
Which, sounds impossible. Trying to objectively measure a feeling of looseness seems like trying to objectively measure how cozy a sweater is.
That's a great way to put it.
Where do you even begin with that? You can't just throw a tape measure at the problem and call it a day.
You certainly cannot. The medical field realized they had to approach this from two completely different angles to get the full picture.
Okay, what are the angles?
So they split their outcome measures into two distinct categories. First, you have subjective patient reporting, which is gathering rigorous data on how a woman actually feels.
Right.
And second, you have objective biomechanical data, which uses high-tech imaging to see what the physical tissues are doing, like at a microscopic level.
Let's start with the subjective side, because that is where the patient's journey always begins, right?
Yeah.
If you walk into a clinic seeking treatment for laxity, they don't immediately wheel out the heavy machinery.
No, definitely not. They hand you a questionnaire.
Right.
The most common starting point is the vaginal laxity questionnaire, or the VLQ. It's structurally very simple, just a 7-point Likert scale.
Okay, so 1 to 7.
Exactly. A score of 1 indicates the patient feels very loose, while a score of 7 means they feel very tight. In a clinical setting, any score of 3 or lower defines the presence of laxity.
It's simple, sure, but
Gosh.
reading through our sources, I found something genuinely baffling about the VLQ.
Oh, the validation issue.
Yes, the medical community uses this questionnaire everywhere. It's the standard for testing non-surgical devices. Yet the original study that introduced the VLQ didn't actually, officially validate it.
Yeah, that is sort of the open secret of early laxity research.
But how does that happen? You can't just build a skyscraper on an uninspected foundation. How did an unvalidated scale become the clinical gold standard?
Well, it comes down to the practical realities of emerging medicine.
What do you mean?
When these radiofrequency and laser treatments first started hitting the market, researchers desperately needed a quick, standardized way to track patient responses across different clinics.
Okay, I guess that makes sense.
Yeah, and the VLQ made intuitive sense to patients. It was easy to administer, and so it just caught on like wildfire. But you are entirely correct. The scientific method demands rigorous, peer-reviewed validation.
Right, you need the math to back it up.
Exactly, and recognizing that gap is what drove the development of much more robust tools, like the ICIQ-VS.
The International Consultation on Incontinence Questionnaire Vaginal Symptoms Module.
Yeah.
I do love how medicine can turn anything into a 10-syllable acronym.
It is a formidable name, for sure, but it earned it. Unlike the early VLQ, the ICIQ-VS was exhaustively validated.
How so?
Researchers didn't just sit in a room and guess what symptoms mattered. They went out into the community, interviewed healthy women, interviewed clinical patients, and built the tool based on actual lived experiences.
Oh, wow.
Yeah, it contains 14 items strictly related to vaginal symptoms and 10 items focusing on sexual matters.
The methodology is really impressive, but the math behind the scoring system is what really caught my attention. They don't weigh all the symptoms equally.
No, they do.
They use these specific multipliers.
Right. The weighting system is designed to reflect the actual burden a symptom places on a patient's life.
I get the concept, but the specific weights seem, almost counterintuitive to me.
How so?
Well, if you check the box indicating you have reduced sensation, that score only gets a ×1 multiplier.
Yes.
But if you check that you have dragging pain in your lower abdomen, or that you feel your vagina is too loose, your score for that symptom gets multiplied by 2.
That's right.
Why is the math insisting that a feeling of looseness is twice as scientifically bothersome as losing physical sensation?
It's a great question, and it forces us to look closely at how we define quality of life.
Hmm.
During the focus groups used to validate this, a really clear pattern emerged. Reduced sensation is undoubtedly distressing, particularly during intimacy, but symptoms like dragging abdominal pain or the profound physical sensation of severe laxity, they tend to bleed into every single aspect of a woman's day.
Oh, I see. Like outside the bedroom.
Exactly. Dragging pain might stop you from exercising. Severe laxity can cause significant psychological distress just walking around the grocery store.
Right.
So the times two multiplier isn't dismissing reduced sensation. It's acknowledging that certain symptoms disrupt baseline daily functioning on a much wider scale.
That makes a lot of sense.
Yeah.
It takes the focus off just the clinical diagnosis and
Yeah.
puts it on the human impact.
Exactly.
And if we follow that thread, the human impact, we have to talk about intimacy. Because laxity doesn't happen in a vacuum. It directly affects sexual function.
It does.
So measuring the success of a treatment has to involve tracking a woman's intimate life.
It is entirely non-negotiable. Any clinical trial ignoring sexual function is missing half the picture. The gold standard for measuring this is the FSFI, the Female Sexual Function Index. It's a 19-item assessment spanning 6 domains.
Which are desire, arousal, lubrication, orgasm, satisfaction, and pain. Right.
Correct. And all those answers generate a total score with a maximum of 36.
But the threshold number in the research that stood out to me was 26.5.
Yes, that's a very important number. If a patient's total score drops to 26.5 or lower, that serves as the recognized clinical cutoff for diagnosing female sexual dysfunction.
Which is fascinating because the data shows that successful treatments, whether we're talking about traditional surgical vaginoplasty or these newer energy devices, they can cause massive improvements in these FSFI scores.
Huge improvements, yes.
I mean, one surgical study noted patient satisfaction rates hitting up to 90%.
Yes, but
But I want to pause here because here's where it gets really interesting. Our sources highlight a major warning flag regarding these treatments. Achieving physical tightness does not automatically mean the treatment was a success.
it is a critical distinction that often just gets completely lost in the marketing of these procedures.
Yeah, there was a specific study on surgical vaginal rejuvenation. The surgeons used validated questionnaires post-op, and they successfully achieved vaginal tightness. The anatomical goal was 100% met.
Right.
But they discovered that this tightness was often achieved at the expense of severe dyspareunia.
Dyspareunia being the medical term for severe pain during sexual intercourse.
Right, so the tissue is tighter, but the patient is in agonizing pain. How in the world can anyone consider that a medical victory?
They shouldn't.
It completely defeats the purpose of improving the patient's intimate life.
It is a failure of care, honestly, which is precisely why these multi-layered outcome measures are absolutely mandatory. You cannot run a credible trial by only tracking laxity on the VLQ.
You have to look at the whole picture.
You must track laxity alongside the PIN domains on the FSFI. If a treatment takes a patient who feels too loose but is pain-free and turns them into a patient who feels tight but experiences severe dyspareunia, you haven't cured a dysfunction.
You've just swapped it.
You've simply traded one dysfunction for another. The ultimate goal must be functional restoration, not just anatomical narrowing.
Okay, so we've thoroughly covered the subjective side. We have the questionnaires, we understand the multipliers, we are tracking the pain,
Yes.
but we still operate in a highly empirical medical system.
Mm-hmm.
Insurance companies, regulatory boards, they eventually want hard biological data.
Always.
So if the X-ray is useless here, like we said earlier, what exactly are doctors using to get objective proof that a treatment worked?
Historically, they relied on a very low-tech method, the two-finger test, where a clinician manually evaluates muscle tone and tissue resistance.
Which seems incredibly subjective.
Highly subjective, and it varies wildly from doctor to doctor. But today, the frontier is vaginal tactile imaging, or VTI.
Vaginal tactile imaging. I'm trying to picture this. Is it similar to like a specialized ultrasound?
It's different. Think of it more as high-definition computerized palpation. The VTI probe is designed to mimic the biomechanics of human fingers, but its surface is covered in a dense array of high-resolution pressure sensors.
Okay, let me try an analogy here. This is where we upgrade from just asking the driver how the car feels to plugging the engine into a full diagnostic computer.
That's exactly it.
Is it sort of like how the touch screen on a smartphone can tell the difference between me lightly tapping an app icon versus pressing down hard to drag and drop it?
That's a highly accurate way to visualize it. When inserted, the sensors on the VTI probe register varying degrees of tissue resistance.
Oh, wow.
It doesn't just take a picture, it creates a three-dimensional topographical map of the tissue's elasticity, measured in kilopascals per millimeter.
That is wild.
It can quantify the exact strength of the pelvic floor muscles during a voluntary contraction, and even during involuntary stress, like having the patient cough.
So it maps the physical tension and bounce back of the tissue in real time. That is brilliant. And VTI is just one piece of the puzzle, right? The sources mentioned other tools that sound straight out of a sci-fi lab.
Oh, absolutely. We are seeing routine deployment of 3D transvaginal ultrasound imaging to measure the exact focal depth and thickness of the vaginal wall.
Okay.
And perhaps most impressively, researchers are utilizing incident dark field microscopy through devices like the cytocam.
Explain the cytocam to me like I'm 15. What does dark field microscopy actually show you?
Well, traditional microscopy shines a light directly through a sample, which washes out soft, transparent tissues. Dark field microscopy essentially illuminates the sample from the side, scattering the light.
So it creates more contrast.
Yes, when you apply this via a cytocam to the vaginal wall, it highlights the microcirculatory architecture. It allows doctors to see the literal capillary blood flow and cellular structures in real time.
Wait, really? So they aren't just guessing the tissue is healthier. They can literally see new blood vessels forming.
They can see the living network of the tissue. And all this objective data, the elasticity, the moisture, the epithelial integrity, is often compiled into the Vaginal Health Index, or VHI.
The VHI.
Right. A score of 5 or less indicates severe atrophy. Taking a patient from a 5 to a 20 on the VHI provides undeniable biological proof that the tissue has fundamentally regenerated.
Which brings up a massive philosophical conflict for me.
Let's hear it.
What happens when the two sides of our coin disagree? Let's say a patient undergoes an expensive new laser treatment. The doctor runs the VTI computerized palpation, checks the cytocam, and the machines declare a total victory.
Okay.
The tissue elasticity is perfect, the blood flow is robust, but the patient fills out their VLQ questionnaire and says, I don't care what the computer says, I still feel completely loose and unsatisfied.
Well,
which measure wins?
the patient wins
Yeah.
every single time.
Really. The subjective feeling overrides the objective hard data. Then what's the point of the expensive VTI machine?
Because if the objective data improves, but the patient's subjective reality remains one of distress, the treatment has failed its primary clinical endpoint, improving the patient's life.
Right. You can't just tell them they're wrong.
Exactly. You cannot look a patient in the eye and say, well, the computer says you were fine, therefore your suffering is invalid. However, to your point about the necessity of the machines, we need them for the inverse scenario.
What do you mean by the inverse scenario?
Imagine a patient says they feel amazing after a treatment, but the objective VTI data shows absolutely zero physical change to the tissue.
Oh, I see.
As a clinical researcher, you have to ask, is this a placebo effect? Is it just temporary swelling?
Right. Did the machine actually do anything?
We need the objective machines to prevent placebo-driven or purely cosmetic treatments from gaining FDA approval as medical therapies. You need the subjective to validate the human experience and the objective to prove the biological mechanism.
Let's talk about those biological mechanisms, actually. The sources bring up a lot of non-surgical treatments being tested right now. Fractional CO2 lasers, erbium-YAG lasers, dynamic quadrupolar radiofrequency, and electroporation.
Quite a list.
It sounds like an arsenal of buzzing machinery. What are these devices actually doing to the tissue to fix laxity?
So the underlying mechanism for most of these energy-based devices, or EBDs, is controlled trauma.
Controlled trauma.
Yes. Whether you're using a laser to deliver pinpoint light or radio frequency to generate thermal energy, the goal is to heat the submucosal layers of the tissue to a very specific temperature, usually around 40 to 45 degrees Celsius.
So we are essentially cooking the tissue slightly.
You're heating it enough to cause microinjuries, but not enough to cause permanent scarring or burns.
Okay, and why do we want to injure it?
Because when the body detects this microtrauma, it triggers a wound healing cascade. Fibroblast cells rush to the area and begin synthesizing fresh collagen and elastin fibers. It also stimulates angiogenesis.
Which is the creation of those new blood vessels we see on the cytocam.
Precisely.
So you purposefully damage the tissue to trick the body into building it back stronger and tighter.
That's the basic idea.
That makes sense for the heat-based ones. But what about electroporation? The note specifically highlighted a study using a jet plasma device, which sounds totally different.
It is different. Electroporation doesn't rely primarily on thermal damage. It uses short, high-voltage electrical pulses to temporarily destabilize the cell membranes.
Wait, high voltage.
Yes, but it's very brief. It creates temporary micropores in the cells, vastly increasing their permeability. This allows active compounds or energy to penetrate deeply, stimulating massive cellular regeneration without the heavy thermal burn of a laser.
And the data from that jet plasma electroporation study was wild. They used VTI and biopsies and claimed a 100.04% increase in vaginal mucosa thickness.
It's quite a statistic.
I have to call a timeout here, though. Doubling the thickness of the tissue, that sounds like a late-night infomercial claim. Is that actually peer-reviewed?
It sounds suspiciously high, I agree, but the methodology was sound. They used the full suite of measurements we've discussed. They took actual physical biopsies before and after to prove the tissue thickens cellularly.
Wow, actual biopsies.
Yes, and crucially, they cross-referenced that with the subjective questionnaires. The patients reported massive drops in their incontinence scores and highly significant improvements in their FSFI sexual function scores.
So it all lined up.
The objective biological thickening aligned perfectly with the subjective functional improvement.
Now, if you are listening to this right now and thinking, this all sounds suspiciously like the beauty and wellness industry trying to invent a brand new physical insecurity just to sell me an expensive laser treatment, you are definitely not alone.
Not at all.
I had that exact thought reading through the data.
It is an incredibly valid skepticism,
Yeah.
and it's a skepticism shared by the FDA.
Wait, if the clinical trials with these rigorous outcome measures are showing such positive results, like the electroporation study, why would the FDA be issuing warnings?
Because there is a massive gap between a tightly controlled clinical trial running complex VTI diagnostics and a local cosmetic clinic buying a laser and heavily marketing it to vulnerable patients.
Oh, I see.
The FDA has issued strong warnings regarding energy-based devices for vaginal rejuvenation because the market got way ahead of the science.
Meaning they started selling the cure before they finished the homework.
Exactly. While the initial short-term data is highly promising, the FDA's mandate requires long-term sham control investigation.
Right.
We need to know what happens to that tissue 5 or 10 years after it's been repeatedly heated or subjected to electroporation. Does it scar eventually? Does it lose sensation over a decade?
Which goes right back to the multipliers we talked about earlier.
Exactly. The rigorous outcome measures we've been discussing, the VLQ, the FSFI, the biopsies, these aren't just academic hurdles. They are the only shield protecting patients from unproven cosmetic trends.
Without these strict measurements, it's just guesswork.
With them, it becomes evidence-based medicine.
It's an incredible evolution. We spent this time exploring how a condition that millions of women used to suffer through, silently thinking it was just an unavoidable consequence of aging or childbirth, is now being evaluated with absolute pinpoint precision.
It really is remarkable.
We've gone from simple 1 to 7 questionnaires to microscopes tracking real-time capillary blood flow.
The shift from silence to precision in women's intimate health is one of the most important clinical shifts of the last decade.
Before we wrap up, I want to leave you, the listener, with something to chew on. Our sources mentioned one more metric, the FGSIS, the Female Genital Self-Image Scale.
Yes.
And it presents a fascinating philosophical problem for everything we've just discussed today.
It really challenges the entire premise of how we define clinical success.
Imagine a scenario where a woman undergoes one of these new treatments. A few months later, the doctor runs the VTI machine, and the elasticity hasn't changed. The cytocam shows no new blood vessels. Biologically, physically, the treatment did absolutely nothing.
Yeah.
But because she took agency, because she actively did something for her body and prioritized her own care, her female genital self-image scale score skyrockets. She feels confident. Her anxiety disappears. And because her self-image improves, her sexual satisfaction completely transforms for the better.
So the objective data says the treatment was a total failure, but the psychological and functional data says it was an overwhelming success.
Exactly. So the question is that a medical failure or a psychological triumph? If the ultimate goal of all these treatments is simply a better quality of life, it raises the possibility that maybe the human mind is the most powerful outcome measure we have.
That's a great point.
Sometimes the cozy sweater just feels cozy because you love wearing it, and no machine can tell you otherwise.
A phenomenal question to end on.
It really is. Thank you for joining us on this deep dive into the science of measuring the unmeasurable. Keep questioning the data, keep exploring, and keep learning.